Maria, I was wondering if you could speak a little bit to the directionality in terms of the locus of control of the vaccination program over the decision-making process. What you've been describing here is very individual-based. The mother has to do something herself, or the child has to do something herself to get vaccinated. Whereas outside the US and most European countries, the vast majority of immunization programs are brought to the vaccinees, or brought to the community, so it's opt-out if you don't want to get vaccinated, not opt-in if you do. How do these communication strategies need to be adjusted depending on whether the program is designed as opt-in or opt-out? I'm wondering if you can speak to that a little bit.
Yeah. Yeah, you're absolutely right that perhaps these, you know, the main points of my presentation are really most relevant for situations like, unfortunately, we have in the United States where, you know, these aren't mandated vaccines, are not, you know, required, and there is a lot of personal decision making that's going to influence uptake and completion. I think that even in countries where it's part of the vaccine program, we still have to be worried about media you know, sort of shifting things away from the progress that we're making. I was hoping to hear something, and maybe it's yet to come, about the media coverage of the recent deaths that were attributed to the vaccine, because I know that that there was a lot of talk in the communities in which I work and other places about what's that about. And so I think that we have to worry about it in terms of people that would be opting out. And some of these strategies could be used to avert that issue. But I definitely think that it's nowhere near as important as some of the other approaches that are organizational level, policy level, that are currently going on in other countries. And hopefully, at some point, this will be less relevant in the United States as well, because we'll have some similar processes.
Could you please tell us about all these mothers may have sons too, and I know that you are not telling nothing about them, and we know that things are getting bad to boys too, or adults, men. What about that? Can you improve this information since from this campaign?
Yes. Oh, I'm glad you answered that. I mean, asked that question, and I wish we had our funders in the room, because that's precisely what we've asked to do in this next phase, is to add a module for parents of boys. When we started this program, it wasn't a recommendation to vaccinate boys, and as I said, we already had to cut it down because of reduced funding. We could only focus on parents. We couldn't focus on adolescents. We could only focus on uptake. So in this new proposal, which I should know within the next few weeks, we're doing several things. We're looking at the step-down intervention without the lay health workers. We're adding a module for boys. We're looking at the text messaging and the agency. Yeah, so we're trying to do those things that we weren't able to do here. In addition to that, we're going to be, because this is specifically developed for Hispanic parents, and we have it available in English and Spanish, but there's also a lot of other low-income audiences in the Houston area and Texas that could benefit. So we'd like to do that as well, to develop versions for others.
Hi, my name is Megan Wysong Harris, and I work for JPIGO. Just wondering, on the iPad app, is there a way to collect the data in terms of which choices are being selected and how often, and some socio-demographic? I might have missed that in your presentation.
Yeah. So absolutely, we actually have the data collection in terms of sociodemographics and other things separate, but we do have a tracking program here, and because everyone has an ID number, that's linked to the other data that we gather elsewhere. But it's absolutely possible and actually very easy to get that data. There's some university protocols that didn't allow us to actually capture identifying information on the iPads, and it has to do with security and firewalls and things that I don't understand. Otherwise, we would have had all the data collection, the tracking and everything, and the intervention on the iPad, but it's absolutely possible. And we will know a lot of things from the iPad that will link to the other data. So we'll know the time spent, the pathways taken, whether things were repeated, whether they skipped a section. So we'll know all that.
And you'll know whether or not they actually got their daughter vaccinated?
Absolutely, yes. We're doing both self-report and medical record review. We want to do, at the same time, do a validation of self-report, but we're collecting medical records.
Thank you.
Would you please comment on the validation of the app application, the messaging and everything? Because just seeing it so briefly, I have a question if the dialogue between the two older women would, of course, send a positive message that the children, the girls, should be vaccinated. But at the same time, it sends a negative message about how awful going to screening is. And then it doesn't seem in this simple spot that we saw to actually clarify that girls will also have to go to screening even if they were vaccinated. So it's just a snapshot, I understand, but related to that, could you comment on your validation process? Thank you.
Sure. Well, I'm not exactly sure what you mean about validation, but again, this is a snippet, and there are many, many other elements, places where we're giving the message of not only vaccination, but screening is important. We actually haven't tested the impact of the intervention on attitudes towards cervical cancer screening, but we are capturing whether or not parents have been screened, when they were screened, and intentions of future screening at the follow-up. So we'll be able to look at that. In terms of, I'm not, like I said, I'm not sure this is what you meant, but I can tell you some of the processes that we followed in terms of developing the scripts and the messages. So we obviously had a multidisciplinary team, including physicians and epidemiologists and others, to make sure that the information was accurate. And then we also did storyboarding, which is before the actual shot. For the actual shooting of the video, because once that's shot, it's difficult to change and expensive. We narrated the scripts and showed storyboards, and then showed that to people and got reactions. We didn't hear the reaction that you're suggesting could be possible from any of the people that we tested it with, although it's certainly possible. In fact, what we did hear was the opposite. We heard people say, oh, that's great that you're reminding people that it's important to get screened, and that and then the relationship between the two. But it's a good point, and it's worth exploring, because certainly, and I don't think just with this, but with any communication strategy, we don't want to do harm, right? I mean, that's as important, if not more important than seeing if it works, is that we don't want to send the wrong messages. So thanks.
Regarding, we didn't see your whole application working, but do you give any information about anatomy? Because I saw that animation, and I think that thing might be a problem. I don't know if you have.
Yeah, so where I started it, if I had started it probably a few seconds before, you would have seen the whole outline of the woman, and then it focuses in to where the cervix is and stuff. We've done lots of testing on images, And I think what you're saying is a really valid point, that you can't just show people a cervix. They have no, for this population, they have no idea where the cervix is. And so we did testing with sort of different kinds of images and came up with the animation that we have there. It is possible that we need to spend, and it's great to have a room full of critics to give us a little bit of some suggestions for how this could be improved. It's possible that it's too quick, right? That it has the silhouette of the woman and then it too quickly goes into the cervix, and so, there's always that possibility.
I would make another comment, because now in Brazil we're shifting from the polio, the Sabin vaccine, the oral, to the Salk, which uses a needle. And it just started, but we see people afraid of, now I need to, my child will suffer. And I saw the three syringes with the needle. Maybe, I don't know, I would change. I don't mind being vaccinated, but does it cause fear? I mean, people get.
Yeah, that hasn't come up as a major concern in our group. In fact, we find that Hispanics in the United States are much more accepting of vaccination in general than other groups, and it may be because, at least along the border in Mexico, when people are ill, when they have an infection, a lot of times they'll get, instead of an oral antibiotic, they'll get a shot. So it's just a more common. We haven't seen that. We take, all of the interventions that we developed are community-based, participatory, research and planning. So we take very seriously involving the community at every step of the way. So not only in the identification of factors that influence the behavior, but also in the creation of messages, the testing of images. Now, having said that, there's only so much you can do, right? And everybody has a timeline and stuff. So did we test every single image? No, we didn't. But that's, these are things that we could certainly continue to look into as we move forward.
Well, thanks for all this information and for the film. I have just a question for clarification. And coming back to the comment, the previous comments, the beginning is with the virus. I'm not sure I heard where they come from. I mean, what are these viruses? So, and several times, it's at least twice I've noted that the vaccine needs to be given before the onset of sexual activity. And then when the two women are discussing that it didn't increase sexual activity, but I don't think I've heard that it was sexually transmitted, or maybe I've missed it. But could you tell me something about that?
I started in the middle. I just picked a spot to start in the middle. I didn't start from the beginning.
How long is
the whole thing? Yeah, so it depends, the length. It depends. It could be as short as about 7 minutes and as long as about 20. Depending on the different pathways that you take. So yes, absolutely. One of the very first things that we assess, and this is part of the tailoring algorithm, is has the person ever heard of HPV before or not? But even if a person has heard of HPV, we still give them information about the transmission, if a person has never heard of HPV, then they get more. So it's like sort of basic information and more in-depth information. But yeah, maybe I should have started from the beginning, but I wanted to I wanted to show you that just because we've gotten a lot of positive feedback from that animation from the community. They really, really like it because what they've told us, and of course this is qualitative and anecdotal, is that they never really visualized what they had heard cervix, they had heard PAP, but they never really visualized what it looked like. They never really visualized cancer. And so because, precisely because I think that that's a piece that they really like, I chose it to start. But we certainly do have some things before that.
Maybe you should start with the global can map. Just kidding. I thought it was great. And I also really liked actually the 3 injections because I always think of it as the one So seeing the 3, I think, helps reinforce that multiple dosing. But do you have plans at the end of the study, if you determine that it's beneficial, to release that to other FQHCs and other interested entities?
Yeah, absolutely. I mean, what I'd like to do is I'd like to make it a mobile app. So available for download not only on iPads but on phones. So yeah, absolutely. I mean, one of my major interests is broad dissemination and use. So, you know, unfortunately, I've had the experience of people using interventions that I've developed that actually haven't worked, and but they really, really like them, so they ask for them, and you know, and I always say, well, you know, it didn't actually work, but I think that if it works, then we'll do a lot to promote it and make it as widely available, you know, for free. If it doesn't work, I may be a little less, I'm more reluctant to disseminate it.
Yeah.
I have one question. You started your talk about that, the weighing thing, that it's difficult. How do you catch that in your tailoring? How do you help the women that at the end, when they have all this information, to weigh the information that they got? And at the end, in the Netherlands, we see that when they get too much positive information, they get a little bit, they are telling only one side of the story. How did you see that in your intervention? I'm curious about that.
Yeah, I think I'm going to try to repeat it, and you can tell me if I got it right. So you said, how do you help women weigh? And when you say weigh, I'm thinking that you mean like the pros and cons of the vaccination. And then the second part was? Oh, okay. Yeah. So the other part of the question was that there may be some perceived bias if they're only getting too much positive. So I'm going to start with the second part. I actually think that that's an area where this type of program does really well, because we're absolutely not only telling them the positives, since they're hearing all of the worries, particularly people who have low efficacy beliefs. So people with high efficacy beliefs, they don't want to and they don't need to hear all of the potential negatives. At least that's what the studies show, right? But people with low efficacy beliefs, they're hearing that these other women have concerns. And we did definitely struggle with the fact that, well, what if they didn't have this concern and then we're mentioning it? Maybe now that's going to be a concern for them, right? You know, we sort of erred on the fact that, well, this is self-tailoring, and people could choose all of them, they could choose one, they could choose another. But I think simply hearing that there are these other concerns mitigates that effect of, oh, I'm only hearing the positive side of the story. The other one, you know, in other interventions that I've developed, I have sort of taken people through this pros and cons, you know, barriers and benefits exercise, and have even used this graphic of like weighing. And you know, what I've found, at least with screening, and I'm not sure about HPV, is that what ultimately matters is the belief in the benefits. So people can believe, in one of my recent studies with cervical cancer screening, for example, we were utterly unable to change people's negative beliefs about Pap test screening, so that it was embarrassing, that it was uncomfortable, and you know what, it didn't matter. So even though the intervention did not change negative beliefs, it did change positive beliefs, and particularly outcome expectations, that if I do this, I'm going to be protecting myself, enough that it influenced behavior. And so I think that there's still lots of questions around how we deal with barriers and benefits, but we made a sort of a conscious decision not to take them through a pros and cons exercise here.
All right. Okay. All right. Well, let's thank Dr. Fernández and Eduardo for their great talks.